everyone, welcome to the session of Biochemistry 2024 NEET-PG session. So hope you are all doing good. So let us first analyze how the question was. So totally when I analyzed almost every question, not only biochemistry, all the questions were scenario based. That is a new trend of question pattern that is asked in recent years. And it was all structured MCQs only. Then the questions were not too lengthy, but not too short also. Almost a moderate length, or the stem of the questions were of a moderate length. Direct repeats were almost nil. That is the case of biochemistry, I am saying. Direct repeats were almost nil. All questions asked were from the high yielding topics only. Because in biochemistry, I will say, the for NEET-PG exam, the high yielding topic, that must learn topics, I will categorize into only two. That is the metabolic disorders associated with every metabolisms like carb, lipids, amino acid, all metabolisms, the metabolic disorders, including the nucleotide metabolism. Then comes the vitamins. So if you see, almost every questions were from these two areas only, right? Then what I find is, like, unlike asking the vitamins very in a simple way, this time they have twisted. Like, even if we feel that they are all easy topics, but the questions were asked in a bit tricky way. That is what I felt. Then comparing session 1 and session 2. I will say that it is more, almost both are of equal difficulty level, almost a comparable, both session, right? This is the case of biochemistry, I'm saying. Very difficult question, hardly one or two question total. That is one from session 1, and in the session 2 also one question was a bit difficult. So this is what I could find as an analysis of the NEET-PG session August 2024. So we shall see the questions. So this is about the session 1 first. A patient diagnosed with a rare homozygous recessive condition presented with ectopia lentis. In peripheral smear, there was no megaloblastic anemia. Later, it was found to be methionine deficiency. These two are the key for the diagnosis of this case. Which of the following supplementation will help the patient? So the answer here is pyridoxine, that is B6. So let us analyze, or what is this case. Straight away, if you see that ectopia lentis, hypomethionemia, one diagnosis, one metabolic disorder that will come to your mind is definitely homocystinuria. Yes, definitely this is a case of homocystinuria. But we need to know more about this. What is the, why they have said about the megaloblastic anemia there, low methionine level. So let us see the different things that we have to learn or must know in the case of homocystinuria regarding this question. Fine. We all know about the methionine and the cysteine metabolism, right? So we know that the methionine converted to S-adenosyl methionine, which is converted to S-adenosyl homocysteine. Now we will stop here. That is at the level of homocysteine. So this is where we have to discuss. The homocysteine has two fates. Which are they? The homocysteine can either combine with serine and form cystathionine, and later on becoming cysteine and homoserine. And if it is going into that branch, we know that the enzyme is cystathionine beta synthase. And what is the vitamin there? B6 is the vitamin. Fine. Now, the second fate of homocysteine is the homocysteine can be remethylated. So for that, who is the methyl donor? The N5-methyl THFA is the methyl donor. It donates the methyl group to the B12. It becomes methyl B12. And methyl B12 is the one which gives the methyl group to homocysteine, so that methionine is formed. So this is about this metabolism. Now, regarding this case, what type of what is the metabolic disorder here? I told you it is a case of homocystinuria. But we should know that there are two types of homocystinuria. One is the classic homocystinuria. In classic homocystinuria, where is the defect? The defect is in this branch, that is cystathionine beta synthase, and it is the vitamin that is required there is B6. Okay. So if there is a defect in the downward path, that is where it's going to the cysteine, then we know that cysteine level will be reduced, right? Cysteine level will be reduced. Then what about methionine level? It is normal because there is no problem in the upward way. It is the block is in the downward. If the block is in the downward way, upward way, there is no problem. So in classic homocystinuria, if it is classic homocystinuria, then cysteine level is reduced and methionine level is reduced, methionine level is normal. Fine. Now what about that question? In the question it was given, it was found that methionine level is low, which means the defect is here. Okay. So this is not a case of classic homocystinuria. This is a case of non-classic homocystinuria. So, first I am writing it is non-classic homocystinuria. Fine. Now, what are the causes of this non-classic homocystinuria? Two causes are there. One, it can be a defect in the formation of N5-methyl THFA. So, for the formation of N5-methyl THFA, what is the enzyme that is required? The enzyme that is required is methylene tetrahydrofolate reductase. I am writing the short form MTHFR, methylene tetrahydrofolate reductase. So, if this enzyme is defective, then it causes a defect in the formation of N5-methyl THFA. Is there any other defect? Yes, there is one more defect. That is a defect in the formation of methyl B12. So, the defect can be here as well, where methyl B12 formation defect. Methyl B12 formation defect. Okay, so two defects can cause non-classic homocystinuria. Then the question is, if there is a defect of, like in the case of MTHFR, or if it is a case of this methyl B12 formation defect, we know that homocysteine is not getting converted to methionine. So generally what we can say is the methionine level is reduced. So we can say that the methionine level is reduced, but cysteine level is normal. Okay, so this is how we can differentiate between classic and non-classic homocystinuria. Okay, so now we understood that this is a case of non-classic homocystinuria. Then again we have to divide. We have to find whether it is a defect in MTHFR or a methyl B12 formation defect. So how can we do that? It is based on the presence of megaloblastic anemia. So megaloblastic anemia is seen in which case? So megaloblastic anemia is seen in the defect of what is called as the methyl B12 formation defect. Methyl B12 formation defect, megaloblastic anemia is seen, but in the case of methylene tetrahydrofolate reductase, the megaloblastic anemia is not seen. So, if you see that question, you can see that there is no megaloblastic anemia and there is low methionine level. So, which means this is a case of what? This is a case of methylene tetrahydrofolate reductase deficiency. Methylene tetrahydrofolate reductase deficiency. But now we understood what is this case. Now, what is the treatment that I will tell you. So, we will just compare these three homocystinurias. The first one is the classic, the next is the non-classic due to MTHFR or a methyl B12 defect. So you have to tell me, okay? So, in classic homocystinuria, what about the methionine level? Methionine level is normal, right? What about cysteine level? It is reduced. Megaloblastic anemia, it is not seen. Then treatment, the treatment is, in the case of classic homocystinuria, the treatment is, the first one, we have to supplement cysteine because cysteine is less. Second thing is high dose of B6. High dose of B6 is given as a treatment of classic homocystinuria. Okay, now we go to the non-classic. In the case of non-classic, I've told you the methylene tetrahydrofolate reductase deficiency and methyl B12. Both are there. So methionine level is low in either of this case because this spoke is affected or this branch is affected. So methionine level is low. Now what about cysteine level? The cysteine level is normal here. Okay, now regarding the megaloblastic anemia, the megaloblastic anemia is seen in this methyl B12 formation defect. It is not seen in the methylene tetrahydrofolate reductase deficiency. So we have concluded that it is a case of methylene tetrahydrofolate reductase deficiency. Again, the question is what is the treatment? So let me tell you about this one. If it is a case of methyl B12 defect, with the megaloblastic anemia and hypomethionemia. So what is the treatment? The treatment is high dose of hydroxycobalamin is the treatment there, which means it is the B12 that we have to give as a treatment. Now, what about this methylene tetrahydrofolate reductase deficiency? We'll give, first of all, in both of these cases, we know that what we have to supplement is methionine supplementation. Methionine supplementation, that is common to either of this case. Plus, we will give a combination of B12, B6 and folic acid. All these vitamins are given as a treatment. So, now come back to our question. What is the answer? It is not thiamine, it is not biotin, it is not riboflavin. It should be pyridoxine. Okay, so the mechanism of pyridoxine is that it is trying to reduce the level of homocysteine, that is cystathionine beta synthase activity will be increased because of B6 so that the homocysteine level can be reduced. That is the mechanism of action for the or by giving this pyridoxine. So this is how we have concluded that here the answer is pyridoxine. Okay. Now, if in the option, if it was B12, folic acid and pyridoxine together, then that is the best answer. Okay, but as it is not given in the option, from these options that is given to us, we can choose only pyridoxine as the answer. Fine. We are going to the next question. A young female comes to the emergency department after ingesting 10 tablets of phenobarbital. Which of the electron transport chain is prevented in this drug? Okay, so this is a straightforward question of electron transport chain inhibitors. We know the complex 1 inhibitors are rotenone, amobarbital, or we can also write all kinds of barbiturates. Amobarbital and then pyridine A. So these are the complex 1 inhibitor. Okay. Now from this we have to choose the correct answer, that is complex 1, but it is not directly given as complex 1. Complex 1 is what's the function of complex 1? We know that in electron transport chain, if this is complex 1, adjacent to the complex 1, there is a mobile electron carrier which is called as coenzyme Q. Okay, so the function of this complex 1 is to give this electron which is collected from NADH, okay, collected from NADH to coenzyme Q. So, we know that it is the transfer of electrons from 1 to Q. Okay, so what is the answer here? Complex 1 to Q. Going to the next question, a 3-year-old child brought to the OPD with complaints of persistent delayed developmental milestones, macular lesions on the body, hyperpigmented, which are more pronounced on the exposure to sunlight. This is the key word here. All these lesions, skin lesions, are seen when the child is brought to or exposed to the sunlight. So, what is the DNA repair defect? So, if you know that disorders associated with the DNA repair defect, then you can very easily answer this question, because we know that the disorder which is like the skin lesions aggravated on exposure to sunlight is Scleroderma pigmentosa. Scleroderma pigmentosa, where you can see there is photosensitivity. So the lesions are aggravated on exposure to sunlight, and what is the defect or which is the DNA repair defect here? It is a defect in the nucleotide excision repair. Okay, so what are the other disorders associated with the defect in the nucleotide excision repair? One is Xeroderma pigmentosa. The others are trichothiodystrophy. And the third one is Cockayne syndrome. Cockayne syndrome. So this question is, which food item this primary where the primary source is thiamine, especially in Indians. Okay, so that word Indians is very important. What are the sources of thiamine? The sources of thiamine are meat, especially the liver, then fish, then yeast, egg, and then comes the whole grains. Whole grains. What is there in whole grains? Whole grains means the brown layer, which you can see as the Electron layer of the cereals is having B1 or thiamine. Okay. So the word whole grains is very important. And as far as Indians are concerned, it is not the meat, fish, or yeast that is important. Definitely, it is the grains that is important. So whole grains is the source of thiamine. Fine. Now, among the food substance, which are the substances or which are the food substance that contain this whole grain? So we have the options where one was chapati and rice. So chapati and rice, definitely it is rich in cereals. But rice, if one thing we should be very careful, like if the option was like this, polished rice is one option. Okay. Second option is chapati. Okay, then I will choose chapati because when I see that picture chapati, I feel that it is not the white refined atta that is used. I feel that it is the whole grain atta that is used. Fine. Because of that brown color, I'm not sure. But anyway, as the options were not like this, we can choose, it was given like chapati and rice, and it is not given like it is polished rice. So by seeing this picture, I'm feeling that it is white rice only. So where the brown color is removed. But still, we have to choose one option. So among these options, chapati and rice would be the best option, especially it is Indians. And if you see other options, they are not at all sources. We cannot say not at all sources, but not a major source of thiamine. For example, cucumber, onions, they are not a major source of thiamine. Curd is not a source. Vegetable curry, definitely it can contain some amount of thiamine. I do agree. But for Indians, cereals is the most important thing. Fine. So the cereal option is seen only in the option A. So we can choose chapati and rice as the answer. And as I said, if the options were polished rice, second option is chapati, then I will prefer chapati over polished rice because polished rice does not contain the Electron layer. So as the options given is like this, then we can choose chapati and rice. So next is a question where a neonate was brought with the features of lethargy, poor oral intake, on examination cataract seen. And neonate is brought. That is another thing. Urine Benedict's test is positive, which means urine is having some kind of reducing substance. Then it is negative for glucose. So which says that most important reducing substance that we should consider is the glucose, but it is not glucose. So that is saying that it is not glucose. So it should be some other reducing substance. What is the enzyme defect? So we know that in neonate, what is the importance of this age group, neonatal age group? This is the age group where the child is fed with breast milk. Breast milk contain lactose. Lactose contain galactose and glucose. So neonatal period is one hint that this is a case of galactosemia. Galactosemia and cataract was seen. That is also given in the question. So cataract is plus this age group is confirming that this is a case of galactosemia. Now, what are the causes of galactosemia? Three enzyme defects are there in galactosemia. One is the galactose 1-phosphate uridyl transferase. The second is the UDP hexose epimerase. And the third one is galactokinase. Okay, so these are the three enzymes that can cause galactosemia. But classic galactosemia is galactose 1-phosphate uridyl transferase. Now we see the option. The option is a bit confusing. Hexokinase, no. Definitely no. Phosphofructase, no. Now B and C. So what is given, like as a recall, what I could get is like it was not given galactose 1-phosphate uridyl transferase. Instead, it was given like galactosyl 1 uridyl phosphatase. No, that is not the correct way to write galactose 1-phosphate uridyl transferase. These two enzymes are two different entity where this enzyme should be like galactose 1-phosphate uridyl transferase was the option, then I will choose that. But that is not given. It is given in a different way, like 1 uridyl phosphatase. No, if the option was like that, no, that is not the answer. But if the option was galactose 1-phosphate uridyl transferase, then I will choose that as the answer. But as to me, it is given like this option from the recall, from if this is what is given in the option, definitely this is not the answer. Then we have to choose another option. Here it is given galactokinase. It's also a query option. We are not sure about it. So if galactokinase was there and this option is not galactose 1-phosphate uridyl transferase, then we can choose galactokinase as the answer. But again, I should say that classically in Nelson, it is given like in galactokinase deficiency, the sole manifestation, the only manifestation is cataract. Now, if you see this child, it is toxic symptoms are there. Poor oral intake because of vomiting, features of lethargy are there, which is more or less towards classic galactosemia only. Okay, so the case is saying that it is classic galactosemia, but as the option, if this is the name of the enzyme given, I will not choose that as the answer. But if the option was galactose 1-phosphate uridyl transferase, definitely you should choose that as the answer, even if galactokinase is present. Okay, now from these options, I will choose galactokinase as the answer with all the precautions taken. That is, if galactose 1-phosphate uridyl transferase was there in the option, that should be the answer, not galactokinase. As the recall is given like this to me, I am not choosing this as the answer. Hope you got my point. Next is a female patient presented with the chorioethetoid movements, dysarthria and dystonia with following findings observed. Which of the following is the best investigation to confirm the same? Okay, so it is a chorioethetoid movements, dysarthria, dystonia. All these are pointing towards Wilson's disease. Plus, this image is very characteristic. We know it is the KF ring. 99% of the Wilson's disease has this KF ring. So, definitely, this is a case of Wilson's disease. What is the the diagnostic test for Wilson's disease? So for that, let me just tell you about what is this Wilson's disease in the biochemically. Okay, fine. So in the liver, we know that the mutation is in ATP7B. If ATP7B mutation, then copper transporter is affected. If copper transporter is affected. So what is the role of this copper transporter? This transport copper to something else. So this is if this is the blood, it is transported to a protein and that is called apoceruloplasmin. So if the copper is transported via this transporter, then it will combine with apoceruloplasmin to form what is called as ceruloplasmin. And that is how copper is transported in a bound form in the blood towards the target organs where copper is required. Fine. Now, if there is a defect in this transport, what happens? The liver copper will accumulate. So, liver copper accumulates, and some of this copper, instead of going through this transporter, it is spilling into the systemic circulation. And this will result in copper toxicity, because if the copper is transported in the bound form as ceruloplasmin, toxicity won't be present. But as it is not transported like this and the copper is spilling into the systemic circulation, copper toxicity will happen, and that is why it can deposit in the central nervous system, in the pancreas, in the eyes and all. So that is the reason for all the symptoms. Okay. Now coming to our diagnosis. In the diagnosis part, what about the serum ceruloplasmin? If it goes through the proper channel, ceruloplasmin can be formed. So what will happen? Serum ceruloplasmin is reduced. Then urinary copper estimation, it will be increased. 24-hour urine copper, that also you can do. That will be increased. Then the next one is the hepatic parenchymal copper estimation. So this is the gold standard investigation. Gold standard, that is liver biopsy with hepatic parenchymal copper estimation is the gold standard, hence that is the answer. And MRI is also, I think it's not conclusive for Wilson's disease, because in every book it is given like the copper estimation in the liver after biopsy is the best test to diagnose a case of Wilson's disease. And almost one thing more we should always remember: when a patient is presenting to you with symptoms of Parkinson's disease, it's always make it a convention that to rule out Wilson's disease, because most of the time we demarcate them as Parkinson's. Sometimes these Parkinson's-like features is due to Wilson's disease. So please do rule out Wilson's disease if a patient is presenting to you with the features of Parkinsonism. Okay. Now, the next is a patient whose peripheral smear is shown here with the crumpled tissue paper appearance. I don't have to say anything about this. Like, it's asked in all the exam. Whenever I take class also, I should say that without seeing this crumpled tissue paper, we should not go for any exam. That is the situation. So, by seeing this crumpled tissue paper appearance itself, you know that this is a case of Gaucher's disease. And it is the most common lysosomal storage disorder, and this is coming under sphingolipidosis. Okay. What is the enzyme defect? Enzyme defect is beta glucocerebrosidase or beta glucosidase. Okay. Beta glucocerebrosidase or beta glucosidase. So what is accumulated? Glucocerebroside is accumulated. Okay. Now coming to the options, definitely it is the case. The answer is A, glucocerebrosidase. But we should also think about like one more option. A confusing option was given in that question. That is alpha glucosidase. Okay. Alpha glucosidase, remember, this is not, because we know that the other name is glucosidase. So if you know only the name glucosidase, then you will choose this as the answer. But that is not the answer, because it is not alpha glucosidase, it is beta glucosidase. Okay. So that is why I used to say that whenever a question, which is very commonly asked question, you learn all the names of the enzymes possible for that particular. For example, alkaptonuria. 3 names are there for the same enzyme defect. So if there are some questions like very repeatedly asked, if more than one names are there, please do learn all the names and go. Otherwise, sometimes what you are searching for won't be there in the option. Okay. So this is one like that. That is glucocerebrosidase or beta glucosidase, not alpha glucosidase. Galactocerebrosidase defect causes what? Graves' disease. Sphingomyelinase defect causes what? Niemann-Pick disease. Okay. Next question. A 10-year-old child from South Indian states hailing from a poor family presented with symptoms of rough, scaly skin. The child's diet hardly has any vegetables and fruits. After treatment with linseed oil, vitamin A and B, the symptoms subside. Okay. So, what is this nutritional deficiency causing rough, scaly skin? That is Phrynoderma. Phrynoderma is otherwise taut skin or follicular hyperkeratosis. Okay, these are all other names for it. What is the cause of this Phrynoderma? That is excessive development of keratin in hair follicles. This will causes the closure of the hair follicles with the sebum, and because of that, rough cone-shaped elevated papules appearance. So, rough cone-shaped elevated papules, you can see especially in the extensor aspects, like on this elbow extensor aspect of the elbows and all, you can find these this rough scaly skin which is almost looking like a skin of a toad. Okay, and so what are the causes for Phrynoderma? Classically, we know that is one cause we all know, that is vitamin A. Plus, there are other causes like essential fatty acid deficiency plus various B complex vitamins. All these can cause Phrynoderma. Okay. Now, so that is why they are giving a treatment with the vitamin A, then B and linseed oil. What is this linseed oil? Linseed oil is a oil which is rich in the essential fatty acid, that is alpha linolenic acid. Because essential fatty acid deficiency can also cause Phrynoderma. So, a combination therapy was given and the patient improved. Okay. So, this is a case of Phrynoderma. Now, what about this lichen planus and erythroderma is quite unlikely. But what about this keratosis pilaris? It is also having this kind of rough scaly lesion. But this keratosis pilaris is a condition you can see in adolescent age group, and it has nothing to do with nutritional deficiency. So, that is not the answer. Now, let's see the next question. At the age of 12, a boy presented with fingernail abrasions, excessive biting of lips. He also had intellectual disability. Okay, I'm not sure whether hyperuricemia was given there or not. It is also a feature of this condition. Okay. So, in this case, it is a straightforward case of Lesch-Nyhan syndrome. What is Lesch-Nyhan syndrome? It is a defect in the salvage pathway of purine nucleotide, and the enzyme is HGPRTase, which can convert hypoxanthine and also guanine. So, hypoxanthine is converted to inosine monophosphate, guanine is converted to guanosine monophosphate. So, if there is a defect here, then the purines are accumulated and as a result, there is excess of uric acid production here. So, that is why there is hyperuricemia also in this case. So, this is a case of Lesch-Nyhan syndrome and it is an X-linked recessive condition. So, definitely you can see there it is a boy. And what is the classical presentation of Lesch-Nyhan syndrome? Self-mutilation. Not just self-mutilation, it is compulsive self-mutilation. So, usually these children are tied on to their coat or to the chair in which they are sitting because they have all this compulsive tendency to bite their fingers or bite their lips and all. So, that is Lesch-Nyhan syndrome. Along with it, there is a partial deficiency of SGPRTase. That is another disorder which is called Kelly-Siegmiller syndrome. But the presentation is not classical like this. The Lesch-Nyhan syndrome has a severity of the symptoms is also more here. So, this is definitely a case of Lesch-Nyhan syndrome. And I'm not sure whether Kelly-Siegmiller syndrome was there or not, but I just tell you that as an additional point, that is a partial deficiency of SGPRTase with the symptoms is not this much prominent. So that is Kelly-Siegmiller syndrome. Here definitely it is Lesch-Nyhan syndrome. A patient presented with severe abdominal pain, vomiting, loss of appetite. His serum triglyceride was about 2000 milligram per deciliter, which is the apolipoprotein that is deficient. Okay. So whenever you get a question on hyperlipoproteinemia, the first thing I should always, or whenever I am teaching also, I am used to say this, that you have to classify hyperlipoproteinemia. That should be there always in your memory. So what is the classification? The hyperlipoproteinemias are classified into 3. That is with hypertriglyceridemia, with hypercholesterolemia, both hypertriglyceridemia and hypercholesterolemia. This is the classification, and under this we are going to put our Fredrickson classification. Fredrickson classification type 1 is here, 4 is here, 5 is also here, 2 is in this with hypercholesterolemia, 3 is here. Okay. Now regarding this, that is with hypertriglyceridemia. So definitely it is given hypertriglyceridemia. So our doubt is confined to only one branch, that is hypertriglyceridemia. So what are the possibilities there? Type 1, 4 or 5. 4 and 5 is very unlikely. And what is the defect in 4 and 5? 2 defects are there. ApoA5 or a defect called as GPI anchored protein, which is called as GPI HBP1, that is GPI anchored protein. HBP stands for HDL binding protein 1. What's the function of these two? The function of ApoA5 is it is helping in the binding of lipoprotein lipase to chylomicron and VLDL. And what's the function of this? The function is it helps in recruiting lipoprotein lipase to the vascular endothelial surface. Okay, so to the vascular endothelial surface, it is recruited with the help of this. So if these defects are there, any of this defect are there, then what will happen? Then the chylomicron and the VLDL metabolism will not take place, either of this defect. So we know that chylomicron level increased, VLDL level is also increased, which means the triglyceride level is very high because chylomicron and VLDL is carrying triglycerides. Okay, this is not very important or very common also. So every time always rule out 1, then only go to 4 and 5. Okay, now coming to 1. 1, where is the defect? The defect can be in 2 proteins. One is that a defect can be in lipoprotein lipase, which is the enzyme that convert mature chylomicron and VLDL to what? Remnant chylomicron or remnant VLDL. So here remnant VLDL I am writing as ideal. You know, ideal is remnant VLDL. So this is the defect. So if that is the defect also, what happens? Chylomicron and VLDL accumulates. So as a result, there is hypertriglyceridemia. Okay. Now, this is not the only defect, lipoprotein lipase, because we are not seeing any lipoprotein lipase here. Then what is the next defect? That is, for this type 1, one more defect is there. That is ApoC2 defect. What's the role of ApoC2? ApoC2 is the one which activate lipoprotein lipase. So if this is the defect, lipoprotein lipase activation will not take place. So the defect will be the same situation like this metabolism is not occurring. So triglyceride level is very high. Fine. So whenever you see hypertriglyceridemia, you should be able to confine to this branch only. Fine. Now once that is clear, now what is the role of this or why this is given like abdominal pain and all? It's because severe abdominal pain is because of pancreatitis. Why? Because hypertriglyceridemia is always giving a burden to pancreas. So that can cause pancreatitis. So that is the reason for abdominal pain here. So the answer here is ApoC2, not B48, not B100 or ApoA1. So now we go to the next question. A patient with a family history of coronary artery disease presented with the tendon xanthoma. Serum LDL is high, cholesterol is elevated. Okay, so now this is also a case of hyperlipoproteinemia. Session 1 was a session on hyperlipoproteinemia, lipid metabolism. That's what I also felt. Okay, fine. This is like there is an elevation of LDL and there is an elevation of cholesterol. So to which branch it is confining to? It is to the hypercholesterolemia. So under hypercholesterolemia, which we have to think of, we have to think about the type 2. Type 2 is the familial hypercholesterolemia. Hypercholesterolemia. Okay. Now, what is the difference in the case of type 2, or what is the clinical presentation of it? In this case, there is hypercholesterolemia. Hypercholesterolemia is always a risk factor for coronary artery disease. Okay, so patient presenting with abdominal pain, hypertriglyceridemia. Patient presenting with chest pain, then you have to think about coronary artery disease and hypercholesterolemia. Then here the LDL level is high. Okay, so why the LDL level is high? Where is the defect in type 2 hyperlipoproteinemia? The defect is in LDL receptor. LDL receptor is the defect, or LDL receptor uptake. Uptake of LDL by the LDL receptor is the problem here. So LDL receptor is the defect here, or otherwise the internalization of LDL through this LDL receptor uptake. That is the problem. Internalization of LDL through LDL receptor is defective here. Likewise, just like we have seen in the lipoprotein lipase defect ApoC2, here also there is an apolipoprotein, and what is that? ApoB100. Okay, so ApoB100 defect also causes the same thing, and because ApoB100 defect, the ligand is defective for LDL receptor uptake, because when LDL is coming and binding to this LDL receptor, it binds with the help of ApoB100. So two defects are ApoB100 or LDL receptor defect here. Next is the tendon xanthoma. Tendon xanthoma is very characteristic of hypercholesterolemia. So hypercholesterolemia, the clinical features are: 1. Tendon xanthoma. Then increased risk of coronary artery disease. Then corneal arcus is also very particular in hypercholesterolemia. Corneal arcus. Whenever you see a patient with corneal arcus less than 45 years, it's a dictum to that you should rule out familial hypercholesterolemia. So, coming to the options, there are two options here. LDL metabolism is there. LDL receptor defect is also there. It is not VLDL metabolism or lipoprotein lipase deficiency. So, among this LDL metabolism and LDL receptor defect, what we should choose? I will choose this LDL receptor defect, because that is the most accurate answer for this. LDL metabolism is affected, I true, but that is a vague option. More accurate is the LDL receptor defect. So that is the answer. So here the answer is LDL receptor. Next is you receive a text message from your friend John Doe about occupational exposure after he visited his doctor. What is this test used to diagnose? He is not understanding only one test. Rest he is understanding, because nowadays we should all expect patients like this, because they are all searching in the internet, and before coming to our OPD, they are all aware of what are the investigation. They will tell you their diagnosis and what are the investigations to be done. They used to tell us, right? That is the current scenario. So, in the current scenario, I feel that this question is a very apt question. So, the patient is asking, and also once we have written so many things, and the patient definitely will refer to the Google, and when he referred to the Google, he could find the answer for almost every investigation that is done by the doctor, but only one investigation he is not able to understand. So he is sending a message to his friend. So this is the scenario here. I actually extremely like this question, because nowadays these kind of questions should be asked, because that is what we are seeing every day. Okay, so this is saying that I understood all the tests done except this urine coproporphyrin. That term is a bit confusing for him. So, urine coproporphyrin is an intermediate in heme synthesis pathway. Heme synthesis pathway, which is the metal or occupational exposure that can affect heme synthesis pathway. That is definitely lead poisoning, not anthracosis, silicosis, or asbestosis. Fine. So, what is or how this lead poisoning affect our various metabolic pathways? We'll see that. So, lead poisoning was found to be an occupational exposure to those who are working with this enamel paint and all, paint industries and all, because in the paint, lead is used a lot. So, there is a journal in 1952 in the journal, there is an article which is saying that urinary coproporphyrin in lead poisoning. That is an article in 1952. So this article is one of the pioneer article which is saying that there is a excretion of coproporphyrin in the case of lead poisoning. So the conclusion of that article was lead has two toxic effects. It is in 1952. Okay, lead has two toxic effects. One is it interfere with the normal maturation of erythroid cells. So that is why they are saying that stippled cells, or we know that basophilic stippling is seen in lead poisoning. So that is one thing that is given over there. It affects the erythrocyte maturation of the cells. Fine. So that is one thing that is affected by lead. What is the second thing that is affected by the lead poisoning is the heme biosynthetic pathway. That is also concluded in way before in 1952. It was concluded that heme synthesis in erythroid precursor cells is inhibited. And they could find three biomarkers. Like later on, the three biomarkers were identified for lead poisoning. One is urinary ALA, aminolevulinic acid. The second biomarker is zinc protoporphyrin. And the third is this coproporphyrin. Okay. Now, later, this is a journal in the article in 1998, which is concluding that these two enzymes are inhibited by the lead. One is the principal enzyme that is inhibited by lead is ALA dehydratase. So ALA dehydratase, if it is affected, so we can explain that is why the ALA is elevated here. So there is increased ALA. What is the second enzyme that is conclusive that it is inhibited as the ferrochelatase. Okay, so that is the reason why there is increased presence of zinc protoporphyrin. But again, how this coproporphyrin was seen? Because so that is not like why coproporphyrin is seen was not, we are not sure why it is seen. But it is seen, that is for sure. It is seen in lead poisoning. Three biomarkers are there. ALA is there, protoporphyrin is there, coproporphyrin is there. Then why coproporphyrin is there? So for that, there was a study conducted on acute lead treatment or lead on coproporphyrinogen oxidase activity. And this article, it is concluded that there is a dose response increase in the coproporphyrin secretion. That is based on the dose that we are giving, doses of lead that we are giving, there is a excretion of coproporphyrin in the urine, which says that, or which is concluding, or by this journal is concluding in such a way that they are saying that there is a reduced activity of coproporphyrinogen oxidase as well if there is lead poisoning or lead intoxication, or if you are giving a treatment with lead, then it is concluding in such a way. So there is a reduced activity of CpG oxidase and there is excretion of coproporphyrin in urine is concluded by this journal. So coming back to our question, the urine coproporphyrin excretion is seen in lead intoxication. Okay, so that is about the lead poisoning. Now, next question is the patient was advised daily exercise to control his diabetes mellitus 2. What is the glucose transporter expressed when the patient start exercise? This is also a very interesting question because mostly which is the insulin dependent glucose transporter is asked. What are the sites of insulin dependent glucose transporter is asked. This is a very different way of asking this insulin dependent glucose transporter. That is, a patient who is a diabetic patient is starting exercise. So when exercising, when he start exercising, what happens is that it's insulin, there is increased insulin signaling pathways which increases the insulin sensitivity. Okay, so if insulin sensitivity is increased, we know that there are glucose transporter 4 which are the insulin dependent glucose transporter. Okay, so once insulin sensitivity is increased, then the recruiting of these glucose transporter to the surface or to the plasma membrane is also increasing, which means it increases or expression of which glucose transporter is increased. It is glucose transporter 4. In short, the question is which is the insulin dependent glucose transporter, and that is glucose transporter 4. Going to the next question, a patient with a severe abdominal pain, amylase and lipase elevated on imaging stone in the common bile duct. Which enzyme is elevated? Okay, so this is amylase and lipase elevated, and what we can see is that there is a stone in the common bile duct. Okay, so this is a case where cholestasis or bile duct obstruction and the bile flow is obstructed. Now the question here is which are the marker enzymes of cholestasis? Which are the marker enzymes? 3 enzymes are there. Number 1, alkaline phosphatase. It is a marker of cholestasis. Number 2, gamma glutamyl transpeptidase. Number 3, 5' nucleotidase. These are the markers. So, among these options, the answer is gamma glutamyl transpeptidase or transferase. It is not LDH, it is not CPK. And what about ALT? ALT is not a marker of cholestasis. It is a marker of liver injury, parenchymal liver injury. Parenchymal liver injury. So, a stone in the common bile duct will not cause an injury to the parenchyma. So, that is not the answer. So, the answer here is gamma glutamyl transpeptidase. The next question is, which of the following is used for syndromic diagnosis of infected cases like meningitis? So, let me tell you what is the syndromic approach or syndromic diagnosis. Syndromic diagnosis is a approach that we use when in a case of infection can be caused by multiple organisms. For example, pneumonia, multiple organisms. There is a panel of organisms that we expect that a patient with pneumonia can be suffering from, because we want to know which is the organism. Based on that only we can give the correct drug or the antibiotics. So we want to know which is that organism. So whenever there is an infectious case with multiple organisms, then we use an approach called as syndromic approach. Fine. Likewise, so just like I said about pneumonia, the same is the case of meningitis. So there is a panel of organisms where this meningitis can be caused due to. So the most common organisms causing meningitis, we have to test simultaneously. So that is called a syndromic approach. Various pathogenic organisms are tested simultaneously. Okay. So what is the technique that we use for that? It is obviously multiplex PCR. So what is multiplex PCR? Multiplex PCR is a variant of PCR where we are using multiple random primers, which means if we are in a patient sample, we are using primers of various organisms that are causing meningitis. Okay, so various organism panel we know. The doctor who is prescribing this multiplex PCR, he will give which are the organisms that we should look for. So we will set the primer, or we will, in the master mix, we add the primers of all these organisms. So in the patient sample, if that organism is present, or whichever organism is present, you can see those target DNAs will be amplified. Okay, so from the result we can find out which is the organism present in that patient sample. This is called a syndromic approach, and the technique that we use is called as multiplex PCR. If you remember, in multiplex PCR, the very important example I told in the class is it is like a multiplex theater. Multiplex theater means in the same building complex, we can see multiple cinemas are played at the same time, which means in the same master mix, we are adding multiple random primers. What is the disadvantage of this technique? The technique's disadvantage is non-specificity. Non-specific. Okay, so some kind of non-specificity is there, but still they can correlate it with the clinical symptoms. Fine. Second, what is the advantage of this technique? The advantage of technique is that we can get the result within 1 to maximum 3 hours. We'll get the result, which means before the patient if a patient is admitted because of meningitis, we are not able to find out, we need to start the treatment as early as possible. Do a syndromic approach. Better to give it for a multiplex PCR. It is costly. Results we will get rapid, and we can start the treatment at the earliest. So this is what is called as a syndromic approach, and the technique that we use here is multiplex PCR. Reverse transcriptase PCR, we know that is for RNA. So if the organism is due to RNA, so definitely a syndromic approach, it is not, we cannot do only for RNA, and that is not a multiplex PCR. It is only we are using a single set of primers. Then what is nested PCR? Nested PCR is if a patient is having Mycobacterium tuberculosis, but we are not sure whether it is Mycobacterium tuberculosis or not, or we want to confirm whether it is due to that, then we will do a test called as nested PCR. Nested PCR is not for syndromic approach. Only that is targeting on a particular organism. And what is nested PCR? In nested PCR, we are giving, if this is a target DNA, we are giving 2 sets of primers. First, we will give a set of primer called as outer primer. Outer primer, and a PCR reaction is conducted, and we will get a target amplicon of that target sequence based on that outer primer. Now, using that amplicon or that amplified DNA, we are doing a second PCR reaction using inner primers. So, something which can bind to that target sequence, we are again doing a second PCR. That is called nested PCR. What's the advantage of nested PCR? It is highly specific. Highly specific. But we cannot do a multiple organism study simultaneously, which cannot be used for a syndromic approach. So the answer here is multiplex PCR. Next is a patient who underwent gastrectomy for adenocarcinoma. Which of the following vitamin need to be supplemented in this patient? It's a very simple question. Gastrectomy is which is the vitamin supplemented. Okay, so we have to think about something called as the vitamin B12 is the answer here. Why? Because in gastrectomy, we know that because of gastrectomy, the gastric parietal cells cannot secrete intrinsic factor. What's the role of intrinsic factor? Intrinsic factor is required for the absorption of B12. Okay, so that is not possible. So what we have to supplement here is vitamin B12. Patient with history of binge alcohol, that is heavy alcohol intake, presented with altered sensorium and hypoglycemia. plasma glucose level is around 45. What is the treatment that you have to give? So if a heavy alcohol intake, then the most important vitamin that is depleted is the vitamin B1. Okay. So before giving dextrose, the first thing that you should give is a high dose of thiamine. So it should be high dose of thiamine followed by dextrose, not dextrose alone. So just by seeing this 45, don't just push only dextrose. Treat first with thiamine, then with this dextrose. So that is the answer here, thiamine followed by dextrose. So now we shall move to the session 2. In the session 2, the first question is in the Lineweaver-Burk plot, the red arrow shows the normal enzyme, green arrow shows the action of the inhibitor. Okay, so what you can see is like the red, this graph is moving in an anticlockwise direction, so that the x-intercept is moving closer to 0 and the y-intercept is remaining the same. The y-intercept is what? 1 by Vmax. What is x-intercept? Minus 1 by Km. So if this is moving means Km is increased and Vmax is remaining a constant. So what is that type of inhibition? It is a competitive inhibition. And in the classes I have told you a very simple way to remember. If you see an X, it is a competitive inhibition. If you see a V, then it is a non-competitive inhibition. And if you see the Lineweaver-Burk plot as two parallel lines, then it is an uncompetitive inhibition. So the answer here is competitive inhibition. A child presented with recurrent abdominal pain, vomiting, diarrhea following ingestion of a milk-based product. Which enzyme is likely to be deficient? Okay. So what is there in the milk? The milk is containing lactose. The milk sugar is lactose. Lactose, to digest lactose, what is the enzyme that we require? It is a lactase enzyme. What is the peculiarity of lactase enzyme? It is an inducible enzyme. If you remember in lab cooperative, we have seen about the structural genes to produce the lactose metabolism. So lactase is a inducible enzyme. Okay. Now this is a milk-based product is causing the child with abdominal pain, vomiting, diarrhea and all, which means it is a lactose intolerance. So this is a case of hereditary lactose intolerance. Then what is acquired? There is also an acquired lactose intolerance. That is, if you are withdrawing yourself from all the milk-based diet, then I told you lactase is an inducible enzyme. So once if you are not exposed to milk and the milk-based product, then the lactase enzyme will not be produced. So if you start again eating with dairy products, then intolerance like bloating, vomiting, diarrhea and all will happen. So that is hereditary. So that is acquired. Acquired lactose intolerance is there, plus hereditary lactose intolerance is there. So here this child is presenting with, so mostly it is a hereditary lactose intolerance. So the answer here is lactase. Which micronutrient is deficient in this patient with radiographic image given below in a patient with neutropenia, depigmented hair and nails? So what is this radiographic image? So let me tell you a few things. Like when you see this radiographic image, you feel like it is a case of scurvy. Because the picture of scurvy is almost similar here also. Let me tell you a few things about this micronutrient deficiency and what is common between vitamin C and this micronutrient. Fine. The first thing is like neutropenia, depigmented hair and nails. Neutropenia, depigmented hair and nails, anemia. These are all features of copper deficiency. Why depigmented hair and nails? Because copper is an cofactor for the enzyme tyrosinase. Okay, tyrosinase is required for the production of melanin. So depigmented hair and nails itself is enough to say that the answer here is copper. But once you see the image, if you may be confused why it is not vitamin C, only thing is like vitamin C is not given here. So you don't have to get confused with that. But let me converge this copper and this vitamin C deficiency together, how they are related, so that these kind of radiographic like features are seen. Like let me tell you, like the copper is a cofactor for the enzyme lysyl oxidase. What is lysyl oxidase required for? It is required for the structure of collagen, that is in the covalent crosslinks. Covalent crosslinks formation, this lysyl oxidase activity is required. So that is how, if there is a copper deficiency, it causes what? A collagen defect. We know collagen is a part of the connective tissues like the bone, the cartilage and all. Okay. Now how vitamin C is coming here? Vitamin C is required for hydroxylation of proline and lysine. Okay. And that is required for the triple helical structure of again collagen. So that is how the radiographic feature of copper deficiency and radiographic features of vitamin C is having some common features, because both are affecting collagen, both are affecting connective tissue, and hence the development of bone is affected in both copper deficiency as well as in vitamin C deficiency. So let me tell you what are the features, radiographic features that you can see or that you can see in a case of copper deficiencies. Metaphyseal irregularity, loss of cortical sharpness, metaphyseal cupping, then spurs in the, especially in the distal femurs, osteopenia, and increased zone of provisional calcification. So some features is there common between the vitamin C deficiency, that is curvy, and copper deficiency, because both are affecting collagen, which is there in the bones, that is a connective tissue. Okay. So, and more radiologically, how you differentiate between these two, I'm not a radiologist to explain that, but biochemically, how is it related, I have already explained. A child was suffering from phenylketonuria. Necessary dietary control was done, but neurological symptoms persisted. Serum showed normal levels of phenylalanine. Which of the following enzyme is likely to be deficient in this condition? Okay, so which enzyme deficiency caused this particular presentation is the question here. Okay, so for this we'll just see which are the phenylketonurias. We all know one phenylketonuria, that is the deficiency of phenylalanine hydroxylase. It causes classic phenylketonuria. So let us just think about this classic phenylketonuria. The situation is like the patient is having symptoms of phenylketonuria and we are giving a phenylalanine restricted diet. Okay, and the aim of this treatment is to bring the blood phenylalanine level to 2 to 6 milligram per deciliter, and it is achieved usually. Blood phenylalanine level becomes normal and the neurological symptoms is also responding. Neurological symptoms respond. This is what usual scenario in the case of a classic phenylketonuria, where phenylalanine hydroxylase is the enzyme deficiency. But what is given in this question? That is, there is a case of phenylketonuria, dietary control was given, but neurological symptoms persisted in spite of normal phenylalanine level, which says that this is not a case of classic phenylketonuria. So, phenylalanine hydroxylase is not the answer here. Then what are the other possibilities? So, we should think about a non-classic phenylketonuria here. What are the causes of non-classic phenylketonuria? Two causes are there. Let us discuss the most common that you all know. That is, we know that for phenylalanine hydroxylase, tetrahydrobiopterin is required. It has to be converted to dihydrobiopterin. Okay. So, the second cause of non-classic phenylketonuria is dihydrobiopterin reductase. Dihydrobiopterin reductase is required to recycle this tetrahydrobiopterin. So, if that is affected, then what will happen? The tetrahydrobiopterin recycling is affected. So, what is or why there is neurological symptoms here? The reason is this tetrahydrobiopterin that we have discussed is a cofactor not only of phenylalanine hydroxylase but also of other aromatic amino acid hydroxylase as well. That is, one is tyrosine hydroxylase, another one is tryptophan hydroxylase. So it is a cofactor for all these three enzymes. So what happens if the tyrosine hydroxylase is affected? Tyrosine hydroxylase is the enzyme that channels the tyrosine towards DOPA and to dopamine, which means from dopamine we should get norepinephrine and epinephrine. So what is deficient here? There is a deficiency of neurotransmitter. Again, if tryptophan hydroxylase is deficient, what will happen? Then it causes a deficiency of serotonin synthesis, because from tryptophan hydroxylase, 5-hydroxytryptophan and 5-tryptamine is formed. That is what is called as serotonin. So in this case, if there is a tetrahydrobiopterin defect, then all these enzymes are affected and neurotransmitter synthesis is affected. So, in such a situation, even if you give a phenylalanine restricted diet, even if the blood phenylalanine becomes normal, even then the neurological symptoms will persist. Okay, so that is about one cause of non-classic phenylketonuria. But we should also know one more cause for non-classic phenylketonuria. That is, so what I explain is about the recycling. So if there is no problem in the recycling or the dihydrobiopterin reductase, then what we should think is about the synthesis of tetrahydrobiopterin. Where is the synthesis of tetrahydrobiopterin occurring? It is from guanosine triphosphate, GTP. So when GTP is channeled to tetrahydrobiopterin synthesis, three major enzymes required is, one is GTP cyclohydrolase. Okay, that is what is given here, GTP cyclohydrolase. The next is pyruvyl tetrahydrobiopterin synthase. The third enzyme is sepiapterin reductase. Sepiapterin, this is I, okay, sepiapterin reductase, that is what is given as SR here. So if there is a defect or a mutation which causes a defect in any of these genes, then, or genes and correspondingly to the enzyme defect, if it is affecting the deficiency of any of these enzymes, then tetrahydrobiopterin synthesis is affected. Fine. Okay. So we have seen two causes of non-classic phenylketonuria. So if a patient is presenting with phenylketonuria, how will we diagnose that this is a case of non-classic phenylketonuria? So for the diagnosis of non-classic phenylketonuria, the one is measurement of neopterin, which is an oxidized product of tetrahydrobiopterin. Second is tetrahydrobiopterin load test. The third is you can do enzyme studies. The fourth is we can do genetic mutation studies. So by this we can find out it's a case of non-classic phenylketonuria. Once it is non-classic phenylketonuria, then we have to give specifically synthetic BH4. Synthetic BH4 should be given, not only dietary restriction. So if we are giving synthetic tetrahydrobiopterin, otherwise called as sapropterin dihydrochloride, otherwise Kuvan. So we have to give this treatment, then the neurological symptoms will respond, phenylalanine becomes normal and neurological symptoms also respond. Okay. So that is non-classic phenylketonuria. Now coming back to the question, we understood that this is not a classic. So phenylalanine hydroxylase deficiency is unlikely. Then dopa decarboxylase, no, definitely no. Then between B and C, tyrosine hydroxylase. I told you that if there is tetrahydrobiopterin reductase or BH4 synthesis or a recycling defect, then tyrosine hydroxylase, tryptophan hydroxylase and phenylalanine hydroxylase. All these three enzymes are affected. But that is not the primary enzyme deficiency. The primary, we have to say that what is the primary enzyme deficiency that causes tetrahydrobiopterin defect. So tyrosine hydroxylase is partially correct, but that is secondary only. That is because of tetrahydrobiopterin synthesis or recycling defect. Then phenylalanine hydroxylase. If tyrosine hydroxylase is the answer, phenylalanine hydroxylase should also be the answer, right? Because they are all secondary. So tetrahydrobiopterin synthesis is affected. Then phenylalanine hydroxylase and tyrosine hydroxylase, tryptophan hydroxylase, all these enzymes can be affected, but that is secondary only. The question here is, what is the primary enzyme deficiency? Okay, so we cannot give tyrosine hydroxylase as the answer. Then the only choice that is left behind with us is tetrahydrobiopterin synthase. Okay, now in the options I've told you, it is not correctly tetrahydrobiopterin synthase. It is pyruvyl tetrahydrobiopterin synthase. But still we can give tetrahydrobiopterin synthase as the better answer. So tetrahydrobiopterin synthase was there in the option. I will choose this as the answer. But some of the recalls and all from the students, what I could understood is that the dihydrobiopterin reductase was there in the option. But repeatedly when I asked the students, there was no dihydrobiopterin reductase defect. So if dihydroxybiopterin reductase defect is also there, that is also the answer, okay? But as it is not, like in the question, repeatedly asked the students, I could understand is that there was no dihydrobiopterin reductase defect. So then what we can choose is tetrahydrobiopterin synthase, because that is a primary deficiency which causes secondarily affect the phenylalanine, tyrosine and the tryptophan hydroxylase. So the answer here is tetrahydrobiopterin synthase. If tetrahydrobiopterin synthase was not there, dihydrobiopterin reductase was there, then that also can be the answer if this was the option. Okay. So out of the option that is given here, I will choose C as the answer. Going to the next question, the child presented with a fatigue, muscle weakness on exercising. Lab investigation showed that LCFA oxidation was affected. Muscle biopsy revealed the presence of fat vacuoles. What is the probable diagnosis? Okay, this is a very simple question. The child is presenting with the fatigue and muscle weakness because LCFA. So what is required as a transporter of LCFA into the mitochondria? We know that we need carnitine. Okay, so if carnitine is deficient, the transport of LCFA is affected. So the fat vacuoles will be seen, and muscles is one of the organ which depends on fatty acid oxidation as a fuel. Muscles is one of the metabolic fuel of muscles is fatty acid. So fatty acid oxidation doesn't take place means muscle metabolism is affected. So that is why the fatigue and muscle weakness and fat vacuole. So the answer here is carnitine deficiency. Next question is, a patient presented with multiple yellowish raised spots on eyelids and xanthoma on Achilles tendon. What is the likely cause for this patient? So in the session 1, I have already explained about this. Achilles tendon xanthoma. It is seen in familial hypercholesterolemia. Familial hypercholesterolemia. Then what is this multiple yellowish raised lesion on the eyelids? It is xanthelasma. Xanthelasma palpebra. Xanthelasma palpebra. Okay. That is also a feature of hypercholesterolemia. So definitely it is a case of familial hypercholesterolemia. Tangius is not a hypercholesterolemia. Fabris is again not a hypercholesterolemia. Xanthomatosis is not the accurate answer here. Xanthomatosis is just the presence of multiple xanthomas. Again, that is not the correct answer here. It should be familial hypercholesterolemia. A 3-month-old child presented with hypotonia, floppiness, difficulty in feeding, failure to thrive, macroglossia, hepatomegaly. This is a very confusing thing here, hepatomegaly. And in the X-ray picture, what you can see is cardiomegaly. So cardiomegaly is there, floppy infant, and it's a 3-month-old child with the severe toxic symptoms. Almost the failure to thrive is there. So hypotonia with the cardiomegaly and macroglossia. Macroglossia, hypotonia, cardiomegaly. it is helping us to make a diagnosis of what is called as Pompes disease. So Pompes disease is the answer. Then what about how can you explain this hepatomegaly? If you see or if you read through the lines in the Nelson description of Pompes disease, it is given that hepatomegaly is seen. Because it is a lysosomal storage disorder, multiple organs are affected. That may be the reason why there is hepatomegaly. But in Pompes disease, if you read through the lines of pediatrics textbook of Nelson, you can see hepatomegaly is seen in a case of Pompes disease. So, I will choose the answer Pompes disease here. Von Gierke definitely it is not the answer. Epstein anomaly and transposition of great arteries. There are typical radiological features. This is not that. Like a string on egg appearance, what you can see is the transposition of great arteries, and Epstein anomaly, what you can see is the right atrium. It's atrialization of the ventricle, so the right atrium will be enlarged, which will give you a box-shaped heart and all, which is not the feature that you can see here. And again, the presentation of Epstein anomaly is different. The patient will present with, the child will present with the cyanosis and all. TG also, the presentation is different. So hypotonia, macroglossia, cardiomegaly, the answer is Pompes disease. Hepatomegaly may confuse you, but it is given in textbook. So the answer is Pompes disease. A 32-year-old lady comes with complaints of erythematous scaly rash, loose stools and cognitive dysfunction. The rash involved her forearm, neck and face. Okay, so there is dermatitis. Where is the dermatitis? Forearm, neck and face means sun exposed. Indirectly they are saying it is sun exposed. So sun exposed dermatitis, otherwise photosensitive dermatitis, plus difficulty in remembering. So dementia. So the second D is coming. Dementia. The first D dermatitis, second D. And what you can see is she admits that she is eating corn-based diet. So what is the problem with corn-based diet? There is decreased niacin, because the niacin is found. Two school of thoughts are there. Two textbooks are saying two different reasons for it. One textbook is saying that it is found, that is in the corn, the niacin is found in a bound form. Bound form called as niacin. There are some other books which says that the level of tryptophan available in corn is low. So tryptophan is the source of niacin or B3. So that is another reason for niacin deficiency. So whatever may be the reason, there is niacin deficiency, which this is a case of pellagra. And what is the supplementation that you have to give? You have to give nicotinamide as the supplementation. Next question is a female with a 7.2 hemoglobin, MCV low, MCHC low. So microcytic hypochromic anemia with hemoglobin low, so the suffering from iron deficiency. Total iron binding capacity is increased. What is your transferrin saturation? We know that transferrin saturation and total iron binding capacity is inversely proportional to each other. That means if here the transferrin saturation is reduced, because that is the one which binds to the iron. So when saturation of the transferrin with the iron reduces, means the iron in the blood is reducing, the blood level of, there is decreased blood iron. That is why the amount of iron which is saturating the transferrin is reducing. So transferrin saturation reduced, blood iron reduced. So that says that it is a case of iron deficiency anemia. Iron deficiency anemia. So what will happen to the total iron binding capacity? More binding sites are there, right? Because iron is deficient. So that is increasing. So these things always go in two direction, two way. Like transferrin saturation reduced and total iron binding capacity increase. So this is a classical case of iron deficiency anemia. So the answer here is reduced. Mother came back to see her child suffering from difficulty in breathing. The child had contact with rotenone. So that is it. So session 1, there was a question on complex 1. Like that, this is also an inhibitor of electron transport chain. Session 1, there was a question on homocystinuria. That difficult one is a non-classic homocystinuria. Likewise, in the session 2, there was a non-classic phenylketonuria. That is why I said difficulty level is almost comparable. and she was taken to the emergency department. What is the likely cause of her death? Rotenone, I told you that it inhibits complex 1. So we all know complex 1, but just by knowing complex 1, we cannot get the answer because we should know the other name of complex 1. The other name of complex 1 is complex 1 is the complex which transfer the electron from NADH and give to ubiquinone or coenzyme Q. So what is the name of complex 1? NADH, ubiquinone reductase, or some book says oxidoreductase as well. So even if it's a reductase, that is fine. So this is NADH ubiquinone reductase, because by transferring the electron, it is the ubiquinone is getting electron. So what happens to ubiquinone? It is getting reduced because gain of electron is reduction. Loss of electron is oxidation. Ubiquinone is getting electrons by complex 1. So it is getting reduced. So NADH ubiquinone reductase inhibition, complex 1. Now the last question. A patient of hypertriglyceridemia was started on medication. He then developed a flushing, hyperglycemia and elevated liver enzyme. Identify the drug. The drug is a treatment that we give for hypertriglyceridemia is niacin. So even if we give niacin in the as a treatment for hypertriglyceridemia in the pharmacological dose itself, then it causes a very characteristic side effect, and that is called flushing, which is usually starts from the face. So facial flushing, later on the skin becomes irritant and itching and all these things will start. So this flushing is actually a G protein coupled receptor mediated flushing. How can we prevent it? Some cases we have to give niacin as a treatment. It's a very good treatment for hypertriglyceridemia. But then how can we prevent this flushing? It is by giving a pre-treatment with the aspirin. That is one way to treat or prevent this flushing. Second way is that we can give a prostaglandin D2 antagonist, and that is called laropiprand. So these are the two treatments that you can give for flushing. Now what about the other symptoms? Niacin is like, if it is excess or it at a pharmacological doses, if you are giving, one is flushing. What are the other symptoms of this niacin when you give it as a treatment? How can we substantiate the other features? That is, one is hyperglycemia, because the niacin affect the glucose tolerance. Glucose tolerance is affected. Next is number 3. That is, what is the other problem with excessive niacin? It is the niacin can cause fulminant hepatitis. Again, another dreadful complication of niacin. So, elevated liver enzyme. That is why elevated liver enzyme. So, here the patient developed flushing. So, definitely the treatment that is given is not statins or ezetimibe or fenofibrate. The answer here is nicotinamide. I hope that is clear. So, we have seen all the questions. I hope that this session was useful to you. Before concluding, what I want to tell is, like, if you love life, don't waste time, because for time is what life is made up of. So time is precious. Use wise use of our time, and success is always yours. Thank you.